Hello and welcome to another episode of Plastic Surgery Unfiltered, a podcast at the intersection of healthcare, business, and the beauty industry. I'm your host, Dr. Armando Davila, joined today by my trusty co-host, Dr. David Tur.
Good morning.
How are you doing today?
Great. How are you?
I'm excited to be back. Our episode today, Before Beauty, the origins of plastic surgery. Now, before we start, we've been away for a couple of weeks. You can see we're in a new kind of configuration in the podcast studio, so we have been changing things up at the office, and hopefully this one will give us a little bit more. We had to move everything each time, so this will be more consistent, I hope.
Absolutely.
Yeah.
No, this is exciting.
So Dr. Tur, I think most people think plastic surgery means facelifts, breast implants, celebrities, influencers,
right.
Pillow face. But that's not where plastic surgery came from, was it?
No, and I mean even in modern plastic surgery, the majority of plastic surgery that's done is not aesthetic. It's reconstructive.
That's correct. I think it's like a 1/3, 2/3 ratio, I think, in the ASPS statistics.
Yep.
But more than that, plastic surgery may actually be, or I think is, the oldest form of actual surgery, right? Because
I mean certainly one of the first.
One of the first, right? And I think, right, if we think about it, it's because before there was anesthesia, antibiotics, all this sort of stuff, the safest place that you could actually operate on was, well, the skin, right?
Sure.
And so that's kind of, I think, where it, all started, right? We couldn't enter the abdomen or joints or anything like that. And so, one of the oldest written versions of a surgery textbook is called the Shrishruta Samhita. Do you remember when that was? I think it was
something like 600 BC.
Yeah. So we're talking now it's almost 3,000 years old.
I mean, it's 3,000 years old from India.
From India, yeah. And Shrishruta, right? One of the big concepts that we talk about is nasal reconstruction, right?
Yep.
And why do you think nasal reconstruction was so important back then?
Right. Well, I think that there were certain stigmas around when there were injuries to the nose. I believe it was because of, was it syphilis?
Well, syphilis came in that was technically called
Earlier it was from.
Do you remember? I know.
I can't remember.
So in India, right, the way they would indicate that someone was a criminal. So if you committed a crime, they would chop off your nose.
Right.
And so it was, and I think it's right because the nose is like the first thing you see in someone's face,
Right. And so it's something that's obviously immediately obvious that you're gonna see that. Yeah. And so then nasal reconstruction became important to allow people to kind of reincorporate with society.
Yeah. And so why don't we tell everyone a little bit about how nasal reconstruction is even performed today?
Yeah, I mean, there's a whole variety of different techniques for nasal reconstruction, but one of the workhorses is what's called a forehead flap. And so, we can really get into the weeds and all this stuff. On that, right? But basically, plastic surgeons are masters of understanding blood flow. And even in aesthetic surgery, understanding blood flow is critical. And so even back then, whether they understood exactly what they were doing or not, what they were doing was isolating tissue that could be perfused and moved to another place in the body. And so they would take tissue from the forehead and rotate it down in order to provide skin there, and then eventually divide it, and it would look passable as a nose.
Yeah. I mean, it became known, I think, as the Indian method when they talked about it in comparison to the Italian method later on. We'll get to that. Right. But we still do that. Yeah. So we still do this same almost identical surgery from almost 3,000 years ago. And so it's pretty neat that this was one of the first documented and still existing versions of documentation of surgery, and it's plastic surgery,
Yeah, absolutely.
Now, what do you think is about, what does that say about modern plastic surgery where one of the earliest surgical problems was not about life and death, right? It wasn't about living. It was about your identity, right? Taking who you were and saying, oh, I was a criminal, and now I've been stigmatized forever. You might not be a criminal anymore, right? And now you need to, change that identity, and that plastic surgery helped that.
Right. I mean, and I think that this is something that I think we're going to get into more even in future episodes, but this interplay between reconstruction and aesthetics, that there are reconstructive procedures are meant to restore not only function, but also form. As close to normal. And so if you want to call that an aesthetic procedure, you could think about it that way to some degree, but there's a huge interplay there between the two.
Yeah, I think that's one thing our office really tries to, or our philosophy really tries to focus on, and it seems obvious to a certain degree. Like people come to us because they want to, yes, potentially look better or have something look better, but it's not about it's not always about the result, right? It's not a technical art. It's a emotional one.
Sure.
And really it ties into how people see themselves and their identity, and making sure that vision that you have for yourself is also in line with the surgeon you're choosing, the place you're getting operated at. And I don't think that's changed for 3,000 years, you know.
Right.
Humans are humans.
Yeah, I mean, you want to, I don't even know if they had mirrors back then.
I don't know.
But you want to look in the mirror and see what you imagined yourself to look like.
Yeah. They probably didn't have mirrors, which is why they got away with, like,
right.
It was just like
right. Everyone else is looking at them like, wow, there's like the blob on your face.
Yeah. Yeah, I think that like the next big, like, you know, things took a pause for probably almost 2,000 years after that, and Yeah, 1,000, 2,000, right? Yeah, 2,000 years. And so I think the next big one was the Italians, right? The Renaissance, because the medieval ages and the Dark Ages didn't really work out for most people.
Yeah, I think that there was a reason they were called
the Dark Ages. So, but the Renaissance was the kind of rebirth of, and the next big form of plastic surgery resurgence.
Right.
And that was with both the Brancas, the Vianos, and Tagliacozzi. You know, what do you know about Tagliacozzi? I mean, we talk about him a lot.
Yeah, I mean, he published what I believe was the first real textbook on plastic surgery in the late 1500s.
Yeah.
And before that, you know, nobody had really shared their methods before. And so this was one of the first instances of people really starting to spread this information and teaching plastic surgery.
You know, one thing that's really cool, and maybe Carly can put a picture, like an overlay. I don't know how to do that, but an overlay. But so when I was at Northwestern, we have you know, Northwestern's a pretty big university. They have a library that's beneath the library in the basement that is like of historical textbooks. And they have one of the 5 extant copies of Decretum Chirurgia from Tagliacozzi, numbered in edition. And so and it was super cool. I was like looking it up, and they're like, oh, we have a copy. And so I sent a request to the library, and I got to go down there. I put on the white gloves. I didn't actually turn the pages, but they would turn the pages for me. Someone turned the pages for me. But I brought like a camera that didn't have a flash, and I took pictures. I have a picture of like the actual page that shows the Italian method of nasal reconstruction.
Right, that like very famous image.
And it was so cool that I got to see like the actual book, you know. But I think go ahead. Yeah.
For those that don't know, like if you look, it's throughout plastic surgery, and I believe it's the symbol for the American Board of Plastic Surgery.
I think so. Yeah.
Right.
It's Tagliacozzi.
Somebody with their arm kind of stuck over their head and transferring tissue from the arm to the nose.
Yeah, instead of the forehead. And so that was known as the Italian method. They put you in this kind of like torture device, and the rest of the book is pretty like. It looks like a medieval torture guide. Like he had invented all these tools to like basically like link people together or link parts of the body together to be able to facilitate those transfers. But I think what was important was not the book. Well, the idea that the book represented was important, right? In medieval times, right, most of your skills were transferred by like apprenticeship, right? Like, and most of it was a secret. And the Brancas and the Vianos, same thing, noses. Noses were lost mostly to syphilis, I think. And so
I think that's what that was.
Yeah. And so this was a marker that you were like unclean. And so they kept it a secret. So if you were wealthy and then lost your nose to syphilis, you got to like
be reconstructed.
If you're poor, you lost your nose to syphilis, you wore this marker, again, identity that you were poor. I don't know. I think that the modern correlate to that in aesthetic surgery is really Baker Gordon, don't you think?
Yeah, I mean, you know, I think that up until, Baker Gordon, I think, was really kind of the first meeting where plastic surgeons were willing to just openly share their techniques when it came to aesthetics. Yeah. And we know what a resounding success that had been for 60 years. You know, it sort of educated an entire multiple generations of aesthetic surgeons.
I mean, they even mentioned when we went to Baker Gordon together how not only did it inspire other surgeons, but it really blew open the door for aesthetic surgery in general, right? Like for the public.
Well, a rising tide raises all ships. I think that if you have a bunch of plastic surgeons or in any field doing something where you're having catastrophic results and problems and patients aren't happy, that field is going to quickly die. And so by sharing that knowledge, it raises the entire field, which then raises the public perception of that field, and it enables us to make it much more mainstream, which is exactly what we're trying to do.
Yeah, and I think that's exactly what we're trying to do here. That, again, taking care of yourself and being that best version of yourself isn't something that should be kept a secret. It shouldn't be something that's sort of reserved for a select few.
Or, limited to just the wealthy.
Exactly.
That got their noses reconstructed and everyone else was miserable. Like, everyone should have the right to have their nose reconstructed.
Exactly. And so, and again, healthcare is gotten absurdly expensive, right? Things just are like even materials and supplies cost so much for our practice, but like accessibility and trying to make sure that we get it to the people whose identity it really matters for their identity is important to us.
Yeah.
And I think that's why Tagliacozzi is on the logo, right? Mm-hmm. It wasn't just that he was a good surgeon. We don't actually know. I don't think he was that great of a surgeon, but
if anybody was at that point,
if anyone was. But what he represented by taking the secrets that Branca and Vianos and those very wealthy families held, and by publishing it, I think really lives on through Baker Gordon, lives on through peer-reviewed medicine.
The aesthetic societies, their major mission is education, right? Mm-hmm. Like elevating the field. So, those concepts certainly live on today.
Even what is the name of the aesthetic one you work on? No, the idea that, again, we bring in the community of our injectors and instead of competing.
Allied
Pro. Thank you. Yeah. Can you tell me about that again?
So Allied Pro is the program now associated with the Aesthetic Society that allows non-physicians to be members of the society, and it's largely based on education, mm-hmm. right? So pretty much anybody that's affiliated with aesthetics can join, right? Yeah. So whether it's a mid-level provider, a nurse, an injector, someone providing laser services, or even practice managers, like people in practices, it's just an opportunity for people to come and learn and elevate the entire field.
Yeah, I just think that makes safer medicine, that makes better medicine for people. Again, if the Aesthetic Society is exclusionary and then has non-educated injectors making pillow face everywhere, it actually brings down the entire view of the industry.
Well, I'm going to make an analogy, right? Like, nobody thinks twice about going and getting a haircut, right? If you didn't get your haircut, you'd look a mess, right? So people routinely go and get their haircut because it makes them look better, it makes them feel better. If 1 out of 10 times you showed up to get a haircut, you left with a 12-inch scar across the top of your head, how often would people go and get haircuts?
No,
never, right?
You start to question it.
Yeah, so there's a reason why there's barber schools, and getting a haircut is pretty routine and pretty safe, right? Yeah. And I'm sure back in the late 1500s, plastic surgery was not as well refined as it is today, obviously. But now, because of the sharing of knowledge and this collaborative environment, we can do these surgeries where we put people to sleep with anesthesia, and we do big surgeries routinely, and it's done very safely and very effectively.
Yeah, and I think that we've developed this NOVA protocol here, and the very first thing I did was share it with people, right? Start telling other people about it. I think that bad surgeons hide, and good surgeons teach. And great surgeons, they teach and then let the next generation improve it, Yeah. And so, if you're hiding your stuff, if you're trying to gatekeep it, then that's not really, that's probably not a sign that you're a great surgeon, So the transition I think we can move into is now the next big target was the world wars. And one of the quotes from the Tagliacozzi's book, which is, we restore, let me read it, I'm going to read this one. We restored, rebuild, and make whole the parts which nature hath given, but which fortune has taken away. Not so much that it might delight the eye, but that it might buoy up the spirit and help the mind of the afflicted.
Beautiful.
Beautiful line. That's
and the reality is the philosophy is no different than it is today.
It's exactly the same, right?
Yeah.
But this became a big deal in the world wars, right?
Yeah.
Trench warfare.
Specifically, it started in World War I.
World War I. So, gillies.
Yeah.
We have a lot of things called gillies.
There's a lot of instruments. Gillies,
yeah. And, why did the war accelerate plastic surgery?
Well, I mean, for one, things like anesthesia and antiseptics were developed in the mid 1800s, and so by that time, surgery had evolved a lot. Like we could do much more what looks like modern surgery today than we could before that. Right?
Okay.
Before we'll say the 1840s. But you also had this huge volume of injured soldiers coming back from the war with horrible injuries, burns. The technology of war had advanced probably faster than the strategies had, and so you had these huge volumes of casualties that were coming back. And so I want to say Gillies operated on something like 11,000 patients. When performed 11,000 reconstructions.
Yeah.
And he developed a lot of the, again, some techniques that we still use today, things like tube pedicled flaps. And again, this goes back to the very basic tenets of plastic surgery. Now, I think they probably had a much better understanding of blood supply and, the blood vessels, how pedicled flaps work than they did back in 600 BC. But the concepts were pretty darn similar.
I mean, I think the origins of what modern plastic surgery even is, and the subspecialties of plastic surgery, which many people do not realize exist,
right.
Actually probably emerged from the World War. So what are those other subspecialties?
Yeah, I mean, like within plastic surgery, I would say the main subspecialties, you have pediatric and craniofacial, you have microsurgery and reconstructive surgery, you have aesthetic surgery, hand surgery, and then if you want to lump this in, probably burn reconstruction as well.
Burn reconstruction, yeah. I think and a lot of those were born of the wars, right? Burn reconstruction
Mm-hmm.
seems obvious. Hand reconstruction may seem like an odd one for people, but it very much follows principles of blood supply, that form and function. Microsurgery came much later because of technical issues.
I think microsurgery didn't come about until the 70s.
Yeah.
Was the first descriptions of free tissue
it's
transfer.
Just technically difficult.
Just so people know what microsurgery is, basically it's moving a piece of tissue from one part of the body to another, but actually detaching those blood vessels and under a microscope hooking them back up somewhere else.
Yeah, so you needed the microscope, you needed the lenses, you need the equipment. That's right. Fine. So that's a little bit more challenging. But, and craniofacial also from disfiguring face injuries. So nearly every subspecialty in plastic surgery was born of the wars, and we've maintained those, and like you said, this is 60 to 70% of all the plastic surgery that's performed is actually that type of surgery, not aesthetic
reconstructive surgery.
Yeah,
absolutely.
And so, but the important part, we're going to do a whole other episode on this, is that form follows function and function follows form. And that if you go to a surgeon and in pursuit of form, in pursuit of beauty, they destroy your function, then they probably weren't as a purist of plastic surgeon, or they probably weren't a plastic surgeon at all.
Right. I mean, and I think, like you said, I think this will be a great episode for another day. But most of or all of the pioneers in aesthetic surgery came from reconstructive surgery.
Okay.
And so a lot of the techniques that they used, they developed initially that skill set within reconstructive surgery and then started applying it strictly to aesthetics.
Speaking of pioneers, I mean, let's talk about why they call the plastic surgeon the surgeon's surgeon. Joseph. Let's talk about Joseph Murray.
Yeah.
So
I bet a lot of people don't know this.
Okay, go ahead. I didn't actually think I knew this, but you told me yesterday.
So Joseph Murray, it was in 1954.
Yeah.
So he performed the first kidney transplant. He was a plastic surgeon.
Yeah.
And he ended up winning the Nobel Prize for it.
Yeah.
And so I think that, to me, that's one of the biggest examples, and it's part of what attracted me to the specialty. Obviously we're both engineers, we're innovators. I've invented devices, things like that in the past, but plastic surgeons throughout their entire history have been innovators. And one of the things I particularly love about plastic surgery is, like in general surgery, often it was more of a diagnostic dilemma, right? Like, does this person have acute cholecystitis? Once you figure that out, the operation you do is pretty prescribed. Plastic surgery to me is the opposite. You have a problem. This person has a huge hole in their face. How do you fix it? We literally have an entire concept called the reconstructive ladder, and you can work your way all the way up from, Shruta's, forehead flap method up to massive multi-free flap reconstructions. And so, but there's no prescribed operation for almost anything in what we do.
Right.
And even in aesthetics, that concept holds true, right? Every patient comes in and it's like, I want a breast augmentation. There isn't like the big red button you push for breast augmentation. We have to customize every surgery down to almost the millimeter to suit that patient's needs.
To get a great result, right? And there's no one way to do it either, right? Like you could still get a great result from two different surgeons with two different strategies.
With almost two totally different techniques.
Correct.
And but that innovative spirit, I think, is what kind of drives plastic surgery. And to get back to your question about why they call us the surgeon, it's because we provide, on the reconstructive side, we provide service to almost all of the other specialties.
Right.
You know, plastic surgeons are the ones that they call when there's an issue, right? When you have a total knee replacement where the wound breaks down and now the implant is exposed, or someone had heart surgery and the wound opens and now the heart is exposed and needs to be covered, or someone had a huge tumor in their face and it was resected and that needs to be reconstructed. So we work with other specialties all the time in reconstructive surgery. And again, it's, you know, every patient is a little bit different, and so even though you have this huge toolbox of techniques, you're selecting the right tool and maybe using it a little bit differently in each person, which to me is like the cornerstone of innovation. I
mean, there's a lot to dissect there that you said. I think I'll go back to your comment on the different ways there are to approach a breast augmentation. Again, something that is like relatively straightforward on a superficial level, right? And we do specialize quite a bit in sort of fixing like kind of the botched or whatever breast augmentation. I don't want to necessarily use that term, but like
suboptimal results after other aesthetic surgery.
And it's interesting, right, where you can actually see when we go into the person's body, like this sort of misunderstanding of the anatomical concepts, the blood flow concepts, the core elements, because some surgeons who start doing this kind of as a side gig just think that it's about like jamming an implant into someone, and it's not, right?
Yeah.
And go ahead.
Yeah, I mean, I think as a field, like, like we said, every little thing matters, right? How much you dissect the muscle, how much you dissect to the side, the size of the implant. I mean, there's so many factors that go into it, and every single one of those is a decision when you're planning that surgery.
Sure.
So every surgery has some degree of of creativity and decision making.
And that's why we try to, use 3D planning, use customized planning to get some of those decisions off of the table, or even help the patient understand, right? Because if I, even today, right, if I told a patient, like, oh, your nasal reconstruction is going to take 5 stages, they're like, what, I need 5 surgeries to like fix this tiny, and sometimes it doesn't have to be the whole nose. It might be like a small, like centimeter and a half. I think, what is it, 2 centimeters for forehead? Yep. 2 centimeter hole on your nose, and suddenly you need 5 surgeries, and you're like, that seems a lot. But that complexity is part of the magic for us.
We were talking about innovation and breast augmentation. It made me think of one of my favorite stories that I'd heard. So, I trained in general surgery at University of Michigan, and there's a story of the transplant surgeons who had done a liver transplant, and every time they went to close, it was compressing, I believe, the vena cava, and the liver was going down.
Okay.
So they were like, this person's going to die if we don't figure this out. So they called, who did they call?
Plastic surgeon.
They called the plastic surgeons. And I can't remember exactly who the attending was, but they came in and they put breast implants under the liver to prop it up so that it wouldn't kink off the vena cava. And I believe that person probably still has breast implants on their abdomen. But
you don't think they go and got them back?
I doubt it, because it probably would have kinked the cava, I guess. I don't know. But I just thought that was such a cool story because, again, it's like you get called in the middle of the night and you have a problem that no one's really ever encountered before. And it's like, we have this huge toolbox. How do we fix it?
And it seems like that is something that would be rare, but every consult day, I have a patient who has a problem that is a bit unique and that is not in a textbook and that needs some kind of unique solution. Right. And that's my favorite kind of work to do,
Yeah,
like helping people figure that out.
Like I said, and that was really one of the big things that attracted me to this specialty was the difference between the diagnostic dilemma and the treatment dilemma. Mm-hmm. And I think that's really like at the crux of plastic surgery.
Yeah, I think that plastic surgeons are ultimately not defined by a certain body part, right?
Or disease state.
And that is really cool.
Yeah.
And I think something that people may not even realize.
Well, again, we started the whole podcast off this way, right? That most people think of plastic surgery as boob jobs and tummy tucks and that kind of stuff, but the majority of plastic surgery is reconstructive. And I think that, this gets back to training, and we've talked about this before. And I think that, there's a difference between going to a board-certified plastic surgeon who has completed a full residency, either, an integrated residency in plastics or training in general surgery with a fellowship in plastic surgery, And most of that training was in reconstructive surgery. So you understand the concepts, you understand the anatomy, you understand the blood supply, all of those things. So when issues arise or things are not as they expect, you can pivot and you can make changes during the operation and fix it.
Okay.
As opposed to someone who's done 6 months of training, a cosmetic surgeon who's
the cosmetic surgery board, if you go to their website, they're not an ABMS board, not a certified board by the American Board of Medical Specialties, not recognized by any institution.
Right.
But they will show on their website proudly that we certify people who have done way more cases, way more facelifts, and way more tummy tucks before their certification than plastic surgeons. How do you answer that challenge?
Yeah, but they haven't done a full training program in reconstructive surgery. And
okay.
so,
but what does that matter? If I'm getting a facelift, why do I need someone who's done reconstructive surgery?
I think when issues arise, you fall back on your reconstructive concepts.
Yeah. I mean, I think that like people misunderstand the ratio of training, right? Like, when you are like, let's say you get a cosmetic surgery board certification and you've done, I don't know, 25 tummy tucks or whatever number it is.
Sure.
Once you actually start practice, you will dwarf that number. Again, we do 300 cases plus a year. Like you will dwarf that number in 3 months, 6 months if you're like actually operating, right?
Sure.
And so that ratio and being like, oh, well, the number for plastic surgeons is 5. Again, we do more than 5. That's like some chart minimum.
Right.
And that's not really what it's about. It's about the core principles of understanding what happens when you liposuction and do an abdominoplasty.
Because you've done thousands of operations as a resident, all focused on, and literally in every operation that we did, before we would discuss the plan and the anatomy and understanding things like the blood supply to whatever part of the body it was that we were going to be operating on.
I mean, like, obviously plastic surgery residency is very hard to get into. So it's also some of the smartest people that come out of medical school. And we also go through rotations with all these subspecialties, neurosurgery, burn, like why is training for being a plastic surgeon as long as being a cardiac surgeon or a heart surgeon or a brain surgeon?
Yeah, I mean, because I think there's a lot to learn early on in the training. Now, again, you were an integrated resident and then I was independent, meaning that you did a direct plastic surgery residency where I did general surgery. So we came in with a little bit different knowledge base. But the point is that we had exposure to a huge variety of medicine, a huge variety of surgery before we actually got into the meat of the plastic surgery training. And so I had spent time with a variety of different specialties. So again, I'm not an orthopedic surgeon or a neurosurgeon, but I've seen those cases. I know a little bit about what they, how they think, a little bit, at least enough that when they call me, it's like, okay, I've seen this before, and I understand those concepts.
I think it gives you a better perspective and judgment, right?
Sure.
Like cosmetic surgery to me and cosmetic surgeons don't necessarily produce lesser surgery. I think they can be great surgeons, right? But cosmetic surgery without kind of that true depth of surgical training is lesser judgment, and the ability to make those calls appropriately, and you continue to learn it over time. But yeah, like I think it's a big journey, right? We started in plastic surgery, cosmetic surgery, arguably with the reconstruction of the nose,
right?
And it became what it has become because people chose to stop hiding what we do and started sharing it. And I think that's something that we want to kind of continue, right?
Yeah, I mean, I think that's that is one of our big missions here, is to normalize the practice of plastic surgery in this area. I think when we've talked about this on the podcast before, when you go to some of the bigger markets like New York and
California
and Miami, plastic surgery is much more normalized.
Or even like Korea, Turkey, all these other countries, right? And even in the UK, like in Europe,
Yeah, but in Pittsburgh, I think it's still something that's kind of whispered about in the shadows a little bit, and it shouldn't be. Like I said, nobody thinks twice about going and getting a haircut, and people shouldn't feel shame about coming and doing something for themselves.
Yeah, and I think that when people reduce what plastic surgery is to simply a state of vanity, they're missing the entire history. They're missing the entire
100%.
Focus of what we've done. It's always been about restoring, what either life or trauma or disease or aging or whatever it is has taken from us.
Right.
And just like you wouldn't say, oh, my heart is aging, I'm not going to take this beta blocker, I'm not going to take this statin because I want my heart to age gracefully. Right. Why do we do that to the rest?
Well, I think, and again, I think that because, let's say you need a cardiac bypass, the alternative is that you die, right? Like the things that we do, the alternative is not that you die. And so it's not about extending life, it's about improving the quality of life. And I think that gets discounted sometimes, but the reality is, how many people have you heard say, well, I wouldn't want to live that way, right? If you're in a nursing home and you can't clean yourself and you're a mess, and it's, is that really a way to live? No, you have no quality of life. So what we do, not only now in Reconstruction, we save lives all the time, right? Because you can't just leave a heart exposed, right? But particularly in aesthetic surgery, we're improving the quality of life.
Yeah.
And I think that's really important.
I think that is. I mean, we'll wrap up pretty soon, but I think that ultimately plastic surgery is not about that artificiality that I think most people consider. It's about making people whole. It's about that kind of restoration. And I sometimes wonder, is one of the reasons why people in the United States struggle with plastic surgery is because we also sometimes devalue our life when we're living it. We think a lot in this country about when I retire and when I do this and when I, it's all about one day I will start living a better life. Right. And the next thing you know, life has passed you by. And it's something that's not in the lexicon, I think, of America for the most part. Yep. But I think times are changing, and
I think so. I sure hope so, especially here in Pittsburgh.
Especially here in Pittsburgh. So, well, we've got a couple great episodes coming up for everybody. They'll tie in here. We'll talk also about one of the episodes coming up is why lies spread faster than truth. We're also going to talk about a little more on GLPs because that's still hot in the news, and we're excited to be back.
Yeah, let's do it.
Thanks everyone for joining us.